Yes, so I'm ready with the next case. This patient is again having a cataract in the left eye, and I think okay. So she has 636 parts vision, and she has proliferative diabetic retinopathy. She has been lasered over the years several times. She has had a PRP. She has had received multiple intravitreal anti-VEGF injections. She had NVI, and she has a rigid pupil, which the NVI has regressed a bit, and we are planning to not use any devices to dilate the pupil, because we don't want to try to unnecessarily disturb the pupil by stretching or anything. So let's see if we can manage that. Otherwise, we'll if we need to do something beyond it, we will as the course.
So can we have the microscope? Yes.
ऐसे रखिएगा जी, नारायणी जी, लाइट में देखना है अब आपको, और as you can see here, the iris is
again a mid-dilated kind of a rigid pupil.
Yeah. No? And there is a like a ring of fibrosis along the pupil edge. So if I tend to stretch it, it will break. But if I really need to do that, I will do it. Otherwise, I will try to operate through this pupil.
If you need to do it, what device would you use?
So if I had to do something, I would use a minimalistic iris hooks. Because that way I have control on how much I'm going to stretch it. I would probably just, kind of dilate it by say 10% or 20%. Because if I use any of the rings, I'll have to really stretch the pupil, which might just cause the NVI to, become active and bleed. So, because with iris hooks, you have total control. I do love the Malugin's ring and even Bhattacharjee ring I'm using regularly, the B-hex. So, but let's see how it goes. I'm starting off now. And again, we are under topical anesthesia, but the patient is a little sensitive as well.
What is your site of your incision right now?
So I have made 2 incisions. See, I'm sitting at 12 o'clock. Right. And I have one at the infranasal. This is the left eye. So this one is infranasal at about 8 o'clock. This one which I'm using now. And the other one is at about 1:30 o'clock. And my main incision is a clear corneal one, which will be at in the supranasal quadrant. Usually I make my incision standard.
Superior incisions or temporal incisions?
I always do 135 degrees because that's where my SIA is planned. So this is where I like to make my incision. That's 135 on right eye or left eye.
So it's supranasal or supratemporal incisions, right?
Yes, absolutely, yes. So.
And you made a side port and then you hydrated the wound. So any reason for that?
No, I did not hydrate it. I just kind of put 0.1 ml of intracameral lignocaine. Now that served 2 purposes. One was anesthesia, and second, it tightened the chamber for me to make the main wound. So I don't use visco from the side port. I use just BSS or lignocaine 0.1 ml to tighten the chamber for me to make the main incision. That gives me better control. And viscoelastic tends to escape, so you're not sure about the kind of how hard the eye is. This way I know exactly how hard the eye is going to be. So.
And you're making the rhexis through the main wound?
Yes, I'm making the rhexis right now through the main wound. I'll try to make it as large as I can. So for now, see, there's one good thing. I mean, one important thing which for those surgeons who use, we are using Viscoat here because that's what was available. With Viscoat, it's not great to use the 26 gauge cystotome because it's so viscous that you will not get a good kind of thing on the capsule. So it's great to switch to a forceps when you need to.
Yeah, so when you're using Viscoat, it is very difficult to make a rhexis with the capsulotomy needle, and right. It's great for a great if you're using a rhexis forceps. Helon that way is more easy if you're wanting to.
Absolutely, I completely agree. So I'm just trying to run just inside the pupil. In usual cases, I would use a rhexis marker, which gives me an exactly 5 mm, but here there's no point because my pupil is smaller than 5 mm. So we've now managed to complete the rhexis. This is good.
So Gaurav, do you take any precautions while you're doing this step, the hydro step, if it is a small pupil?
Yes, I would be very, very careful. I would just, kind of use a hydrodissection cannula, just lift up the capsule gently. I would just kind of lift up the capsule a little bit and then give a gentle fluid wave and would not allow, you can actually do the fluid wave even without going under the capsule. If, you can just be right inside, just above the edge of the rhexis and just push a fluid wave. It sometimes goes very nicely. But I think with good control and very small 0.1 or 0.2 ml bursts, and then depress the nucleus because I don't want the fluid to get trapped behind. And of course, I don't want to touch the iris in any way at any point. So,
right. So you've done a hydrodissection. Or,
anything particular you wanted to say, Saurabh?
No, I'm just asking you, would you want to do a hydrodissection or delineation? Because this.
No, I don't do a delineation at all except for posterior polar cataracts.
Right.
So again, there was this question whether you want to use your bevel up or bevel down during the insertion.
So, it's kind of how you learn to do it. I have learned because, if you go bevel down, then you have to rotate it and it takes an additional maneuver and everything. So I just try to go a little bit twisted to one side like this, and I do that and it goes. But you can do the way you like it. It hardly matters as long as once you go inside. But, anything you guys would like to add would add value to this.
So there were studies a long time back saying that if you do go bevel up, and that was at the time when the straight tips were there, that there's chances of a detachment. But with these bent tips, all those things are taken care of. So you don't actually have to always go bevel twisted down or down or twisted. So you can actually go with a straight bevel as well. But yes, it's just a matter. I also twist my bevel and then I enter. I think that's more
that's what is recommended. Yeah.
So we are trying to do a direct chop, and I've managed 2 small chops for now. So I think chopping is another area where it really helps to learn direct chop. Over the years, you can start doing a stop and chop first, and once you are comfortable, then you can switch to a direct chop. Again, this is a sticky kind of a cataract, so it's not going all the way as easily as it should.
It's a lot softer, yeah. So we had a question.
Yeah. It's soft actually, so that's the whole thing, that it's difficult to chop them very nicely. So I'm just doing some lateral separation and some manipulations, and
the chops are not going through and through because it's very soft, so it's just breaking up.
And then, I try to dissect out this endonucleus even in the hard cataracts, and sometimes in the soft ones. Once you've done a few chops, to create space, sometimes you have this small endonucleus. I call it there's endonucleus because it's the innermost core, and once you have removed this, you create a lot of space. It gives you view of the posterior plate, and then your maneuvers become much easier. So again, now we have 3 chops. So, as you can probably see, and Saurabh, I'm sure all of us do the same thing. I never go under the iris. I never go under the capsule. I like not to I don't like to go with my instruments under the rhexis, especially when there is no view. Especially if there is no view, I would definitely not want to do that.
But I think that's the key to phacoemulsification, that whatever you're doing in phacoemulsification should be under visualization. And even if it's dilated pupil, I would never want to do a maneuver which I can't actually see.
Absolutely.
So, except for maybe during IA by removing the cortex.
So we can see here. Yes, Namrata.
Gaurav, what are your settings right now for phacoemulsification? Are they different from what you did in the previous case?
No, they're exactly the same actually. I've not changed them. So how much is the vacuum? So vacuum is 380. How much is aspiration? 28 is the aspiration or the flow rate. And bottle height is how much? 30? 40? Okay. So we are at 40 bottle height, which translates to about 30 IOP.
So it says 25 millimeter of mercury as IOP. That's what is showing up in our screen.
Right.
And it's about 30.
The thing I want to talk about here is that, there will be a lot of people who are logged in and, who might want to understand this. Now, this is not possible on every machine. So I would definitely not suggest people to go back and start doing low IOP phacos on their regular machines, because, they have to gradually bring it down from whatever they are comfortable with. If they suddenly one day, decide that they want to do low IOP and they go and, on their regular machine, they try to do it, it may be a disaster because you may get a surge. Would you like to comment on that, Saurabh?
Totally agree with it's only with the newer higher end machines which have more control that you can actually keep the bottle height as low as this. And in fact, I think there are not too many, the Centurion and the Signature Pro. And I wouldn't even try it in any other machine as such. In fact, there was a time when people were talking about high vacuum settings on the Signature before the Signature Pro came in, and they were working at levels of about 800 of vacuum.
So I wanted to just interject. Now, what I wanted to tell some of the surgeons here is that there are 2 places where you can sometimes be left behind with small nucleus fragments. One is right under your main incision, and one is under your side port, because naturally the flow is going out. So small fragments of nucleus, at the end of the nucleus removal, can remain just here or here. One has to be careful.
Microscope view, please. Yeah. And I think third place where they can remain is, on the iris crypts. Sometimes
Yes.
it gets lodged into those iris crypts, and then
Absolutely. And also under the, sometimes in the equator. So if you're doing a really hard cataract and, you have these small fragments, especially if you've done a femto where this is more likely to happen if you have created those small nucleus chips, then what can happen is that these can remain somewhere hidden behind the iris in the equator, in the sulcus as well. And, later on they may just find their way and you may have an indolent inflammation. So what I do to prevent that is I'll just show you what I would do for that. Of course, if you notice them, you can remove them. But when you don't see them because they're hiding behind, there's a small maneuver which can help. So I'll just try to show that.
so
Gaurav, we have something under your side port right now. Yeah. Is that correct?
So this is dyspigmentation of the iris actually.
No, not yet. Right, the right side.
Over here?
Yeah.
No, I don't have anything. It's just dyspigmentation of the iris. It's a very unhealthy iris. That's why I was not keen to. There's a lot of irisotrophy. There is dyspigmentation, light colored iris, because this has NVI as well. And now we are.
Alternatively, when you come out with your main probe and your side port at the side port, so you can do those maneuvers. When you just come out, you actively flush those areas.
Right.
Main port and the side port. And do to and fro motions with these instruments so that they get discharged.
Completely agree.
But Gaurav also does a very beautiful thing.
So what do you do, Gaurav?
I'll just show you. Yeah, I'll just show you. I don't know whether I should be doing in this patient, but I'll just show you how it is done. Here, actually, I'm not wanting to touch the iris at all, lest it bleeds, but I'll just try to show one small little maneuver which helps.
Also in eyes where you've had multiple anti-VEGF injections which have been given, there's every chance that there would be, there may be posterior capsule or a rupture, and I'm sure Rajesh has experience of cases.
So now I'm going to show you, Namrata. See, there is a small PC plaque here, if you guys can notice. And also for two things it helps, what I'm just going to show you. I go from the main port with the infusion on, okay, and I'll focus it on the PC. Now I'll just go there and I'll gently, because my fluid is running, so I can actually polish the PC without any PC polisher. There's no sandblasting, nothing. It's just a jet of fluid which is going there. And see, the PC is absolutely shining bright now. There's no plaque left. And second thing I would do is I would just go under the iris here and kind of, flush it with fluid, because the main port is open. So what happens is that there's an active flow of fluid which is coming out here. If there's any small fragment which is hiding in the sulcus or around, it'll just get flushed out and it'll come out, because there's a fast flow of fluid for that 1 or 2 seconds that you're doing this.
So basically just by the flow of the fluid.
All fluidics and all hydro. I call it as my hydro maneuvers of various kinds, because it's the same thing I accomplished that small PC plaque removal. Also, if you have some very irritant cortex which is stuck in the equator of the bag, you don't need to go after it by aspirating it with the aspirating port. You can just go to it from the main port with the infusion on like that, and just just tickle it a little bit, and it just gets released and comes out. So
you can't do it with the coaxial. It's actually because there is a lot of egress of fluid from the main port.
This is more like a hydro vacuuming. So
right, it's like hydro. I call it as the jet polish. So, and I just do it with a regular infusion on and running at high speed. So we are again doing a wound assisted injection of a.
What injector are you using in this?
I'm using the Abbott injector. It's a Technis injector. It's a shooter. And they have really improved this injector over the last few years. Now you can go from a 2.2 incision.
Earlier they had screw type injector, and now I think they have a push injector.
Have you used the screw type injector of Abbott?
I never liked it actually. So the unfolder I used to use very reluctantly. I still use it for my 3-piece sensor lenses. But otherwise I would prefer to use the shooter always. And it works really well for me. This new injector is really good. Last 2-3 years, I've been using all my. In fact, now I'm tempted to use even for my other lenses. I try to look for my Technis injector and the Technis cartridge.
I think the advantage is that the Alcon shooter, it becomes slightly loose after some time. The plunger,
You're right?
Yeah, because it's been manufactured by a third party.
It's generic, yes.
Yeah, so it's a generic. You don't find the Alcon shooter abroad. It's only for the Indian market, and it's been made in India. But this one is their own product, which is by I think Duckworth, and so it's the Kent and Duckworth. Yeah, so that's what.
Also, Saurabh, I think I don't know if you would have noticed it. With the Alcon lenses, I used them for years and I was always very happy. But once I switched to the Technis injectors, I now realize that, with the Acrosoft IQ or the other lenses, you can get a sudden injection. If you're doing wound assisted, it tends to shoot suddenly and you can either hit the iris or you can hit the PC. And, while it's a great lens, but, this is one big problem which I face with them now. So the AutoCert would have solved it, but AutoCert is discontinued. So I now love this injector as my best injector for now.
Exactly, but that's what I was saying, that because that's a generic injector and that's why the plunger gets slightly loose. And if it's a new plunger, maybe for a couple of months, it works great. But thereafter, after a few autoclaves, it's got a white colored silicon, around the plunger, there's a white colored silicon block, which slightly gets loose. And that's why it's no longer as good as it is when it's a new state.
Yeah, that's true. But for all these shooters, I think it's always better to once clean it and then,
बहुत अच्छा हो गया आपका बंद कर लीजिए आंखों को.
Otherwise, what happens is the salt gets deposited.
Yeah.
Yes.
And then it becomes a little.
No, and this is also.
I wanted to show you the machine and the bottle light on the machine. Frankly, if you'll notice, we have 3 OTs here. One of the OTs in which I'm operating right now has a ceiling which is just at about 7.5 feet. So in our modular OT, we have a ceiling which is almost about 9 feet or 10 feet. So, initially we used to have problems because we could never operate on low bottle heights. But here on the Signature Pro, we have a bottle height which is, we still have 2 feet to go above.
Can we have the view from the OT, please?
We're not having your...
Okay, we are trying to get you. Can you show the external camera feed? So, of course, this is a Signature Pro where I'm standing here. And this is the pole and this is the bottle light. And we still have another 1.5 to 2 feet to the ceiling, which is just at 7 feet. So, for those people who operate in OTs which have low ceilings, this is a great thing because, you can operate at very low heights. And, this gives us good, control.
So the feeling we should buy these machines, right?
I don't see that as a reason to buy these machines, but I remember Dr. Rohit Om Prakash telling me that, Gaurav, I can't buy a particular machine because it does not allow me, my ceiling is too low. And so I was telling him just the other day that, sir, now your problems are solved. You can just operate at 40 cc of bottle height or 50 cc or whatever you like, and any of these will fit into any OT. I've seen this actually happen in many OTs. I go to do live surgery so many times. There are places where your ceiling is not high enough. I was in Coimbatore recently, and there again we had the same problem that the pole goes and hits the ceiling sometimes. And I think this
especially after the NABH rules and everybody moving the old OTs into the NABH accredited modular OTs, it does take a lot of space on the ceilings and as well as the walls.
Yeah.
So the ceilings which were a lot higher now have become lower. So the older machines you can't work in some of the older OTs, which have been converted into the NABH modular OT.
Right.